All right, we're just going to give another minute and then we'll get started. So we'll go ahead and get started. Welcome to this week's e-lecture series brought to you by the Emory MSK Radiology section. Just a little bit of housekeeping information before we begin. This is a webinar series that is meant for educational purposes only. All of the interactive features for attendees have been disabled to ensure optimal quality. If you have any questions for the speaker, please email us at this email address, emorymskradiology@gmail.com. At the end of the session, the speakers agreed to do a question and answer session. So this would be your chance to ask questions. If you raise your hand on Zoom, unfortunately, that won't work. So this will be recorded and will be uploaded to the YouTube channel. A reminder, attendees have not been given permission to screen record this talk or any of the talks on the e-lecture series, and it may contain copywritten material. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. All right, with that, I'm going to introduce today's speaker. Today we have Dr. Cody Quirk, who is an assistant professor of diagnostic radiology at the Medical University of South Carolina, where he currently serves as the director of musculoskeletal ultrasound. He did his residency at Baylor University Medical Center in Dallas, Texas, and then completed a fellowship in musculoskeletal imaging and intervention at Oregon Health and Science University. He dedicates a significant amount of his time to trainee education and service. He serves on the ACR Medical Student Educational Task Force, as a reviewer of exhibits for RSNA and SSR conferences, and is actively engaged in the development of an innovative radiology curriculum for medical students. He has a special interest in social media outreach. Not only does he contribute to education by sharing interesting cases on Twitter, but he also runs a podcast that addresses a wide range of topics. Episode themes include tips for applying to a diagnostic radiology residency, how to face challenges one may encounter during training, and a primer for ABR testing. He has moderated a podcast that is designed to explore the perspectives of female academic radiologists and radiology residents. We are delighted he is here today and look forward to his talk. With that, Dr. Quirk, I'm going to turn it over to you.
All right. Thank you very much. And thank you for having me today. And let me see if I can get share my screen with you here. Looks like it's not wanting to pull up my. Are you guys able to see that?
It says screen recording. Zoom would like to record this. That's what I'm seeing on your screen.
Sorry. Sorry, Adam. I'm gonna have to jump out and jump back in again real quick. Sorry about that.
Okay. Everyone, hold on one moment. Having some technical difficulties. Give us 1 sec. You may be still muted, Cody.
All right. Can you hear me now?
Now we do. Yep.
And screen looks good.
Looking good.
All right. Sorry about that, guys. This is what you get whenever you decide to update your Mac operating system just a couple days before you give your talk. So I apologize for that, but thanks to Adam and the Emory MSK section for having me today. It's an honor to be here, and thank you guys for putting all these talks on that have been, I feel like they've been very important this year, especially given everything that's going on. So I hope to add to your education today. We're going to talk all about ACL injuries and their postoperative complications. Like Adam said, I'm at the Medical University of South Carolina. You guys can find me on Twitter at Quirk MSK. Thanks you, Adam, for talking about the podcast and helping getting the word out about that. We've got some more exciting stuff coming this year. We're going to talk a little bit about these nurse practitioner bills that are out in some state legislatures for independent practice. We're going to do an episode on green radiology and making radiology more sustainable. So hopefully that's stuff that interests all of you guys. So, but today let's talk more about the ACL. So we're going to cover just some basics about the ACL, the different bundles. We'll talk about what it looks like on imaging, and then we're going to move into injuries. Most common causes. We know that these happen in athletes, although they do happen in the general population as well, and talk a little bit about that. And then we'll move on to treatment and reconstruction techniques. Dr. X covered that pretty well a week or so ago, and so we won't hit on that too much. I do have a few slides on it though, so that we can talk about. But obviously he's a much more of an expert in that area than I am. And then we'll talk about imaging the postoperative ACL and what kind of complications to keep an eye out for. So we know these injuries well. We've all seen multiple of them. Those of you guys who are currently in your fellowship have probably seen a few ACL injuries so far, and maybe they're pretty straightforward and easy for you, but hopefully I can give you a few pointers to help you out in more complex cases. So basic anatomy, we know that the ACL is a passive stabilizer of the knee, predominantly for anterior translation of the tibia. It does have some role in rotational stability in the frontal and transverse planes, which is why we tend to see injuries of it in cutting and pivoting activities, especially. Excuse me. This also plays some role in reconstruction techniques and recurrent tears that we'll talk about here in a little bit. Just to review the ligamentous restraints of the knee here, we can see here that the ACL provides about 90% of your anterior translation. There may be some other contributions from other ligaments as well, but posterior is going to be predominantly your PCL and posterolateral corner. For valgus stress, we're going to be looking at the MCL, varus, LCL, and then for the rotation, we can see here what I want to point out is that the ACL and the anterolateral ligament are things that we talk about for internal rotation of the tibia, and that plays an important role. So in terms of just basic anatomy, the ACL has two bundles that we talk about. There's the anteromedial bundle and a posterolateral bundle, and they each play a slightly different role depending on the degree of flexion that the knee is in at the time of stress or injury. So if we look at these nice diagrams here showing the tibial footprint of the ACL here, we can see the anterolateral and anteromedial bundles insertion on the tibia. And then we can see how close that is to that anterior horn of the lateral meniscus. And so I believe in Dr. X's talk, there was a question about seeing that signal in the anterior horn of the lateral meniscus with the ACL injuries. It is a common finding. I also find that it seems to be rare that the anterior horn of the lateral meniscus is actually injured at the time. But it can be an area of difficulty when reading MRI. On the femoral side, we can see that the anteromedial and posterolateral bundles have specific insertions here, and they are posterior to this area called the lateral intercondylar ridge, and then the two bundles are actually separated by something called the lateral bifurcate ridge, which you can see nicely here on this arthroscopy image, again, showing that lateral intercondylar ridge where they insert, and then the lateral bifurcate ridge, which separates your anteromedial and posterolateral bundles. As we go through our flexion and extension here, we can see that the anteromedial and posterolateral bundles are going to be slightly different in terms of how taut they are during flexion and extension. So in flexion, we're going to have a more taut anteromedial bundle, and the posterolateral bundle may be a little bit more redundant. And we can kind of see how they change orientation here on the coronal plane as we go through flexion and extension as well. And here's just a nice little recording showing how they move throughout. This would be a a diagram showing something called a double bundle ACL reconstruction technique, where you can actually see they try to recreate the different bundles. This was popular for a little while, but I think it's kind of fallen back out of favor. The idea, though, was to give a little bit better anatomic reconstruction and help account for some of that rotational instability and the different bundles playing their role throughout flexion and extension. So like we talked about, the femoral footprint is going to be posterior to that lateral intercondylar ridge, and then there's the lateral bifurcate ridge that separates the two bundles. On the tibial side, the center of the footprint is parallel to that anterior horn of the lateral meniscus. So here we can see C is actually the attachment of the anterior horn of the lateral meniscus. And you can look at that in relation to the posterolateral and anteromedial bundles here. And so sometimes there's also some thought that there's some blending of the fibers from this anterior root with the ACL itself, which may account for some of that signal that we commonly see in the acute ACL tear. Here's a nice gross anatomy image again showing that how close that anterior horn of the lateral meniscus is to the insertions here of the posterolateral and anteromedial bundles. This is the other knee, so the lateral side is over here for us. So let's move on and talk about the imaging appearance of the ACL. We're going to see a little bit more heterogeneous signal in the ACL than we do in other ligaments around the body. And this just has to do with the two separate bundles that we can make out and some synovium along the ligament itself. So signal sometimes can kind of lead you down the wrong path, although obviously if we have fluid signal within the ACL, that would be abnormal. We're going to look for laxity of the fibers itself. And then there's actually something called Blumenstadt's angle, which allows you to, if you want to measure something, it can give you some idea that ACL itself is lax. And I'll show that here in just a minute. But in the normal ACL, we want a nice taut morphology. It should parallel the roof of the intercondylar notch like we see here on this fat suppressed T2 and this proton density here. So we can see that the fibers do not appear disrupted. I don't really like looking at the sagittal too much. I feel like I can give you a little bit overconfidence in the ACL sometimes, but it is good for looking for that ligamentous laxity. On the coronal here, we can see we want to evaluate it all the way down to its tibial footprint and then all the way up to its femoral attachment here that we talked about earlier. And we can see its nice normal relationship with the PCL here as well. And then some places will actually do these coronal oblique or ACL sequences. I don't find that they necessarily need to be done to diagnose ACL tears. Maybe they're a little bit helpful in more subtle chronic tears, but one thing they are really helpful for is the posterior root ligament evaluation. So anterior and posterior roots of the menisci, the posterior roots of the medial and lateral menisci. But we can see how well it lays out the anteromedial and posterolateral bundles here. So just a nice way to evaluate it. So for that Blumenstadt's angle, if we draw a line down the roof of the intercondylar notch here, and then a line that parallels these ACL fibers, that should be fairly parallel, and anything more than 15 degrees is going to be abnormal. So I'll show you an example of that here in a little bit where it's torn. And then as we go through our axial MR sequences here, we should be able to make out the two different bundles. So yellow arrow is our anteromedial and red is our posterolateral bundle as we come through the mid substance here and then all the way down to the tibial footprint. I find that the axials are quite helpful for diagnosing these. So moving on to injuries here. Isolated ACL tears in the general population have an incidence of around 69 per 100,000 person years, and that's more common in males in the general population. And that has to do with the fact that males are more involved in athletic endeavors. Among athletes, there's about a 1.6-fold increased risk for females. There's a few theories behind that, maybe impingement because females have a smaller intercondylar notch. Females also tend to be a little bit more quadriceps dependent, where the hamstring can provide a little bit of stability against anterior translation of the tibia, and then certain types of compressive forces just having to do with the morphology of the knee. These are common injuries that's seen and reported up to 50% of all knee injuries that occur during sports. And it's important to remember that these are very common in contact sports, although the majority of the injuries are actually going to be during non-contact events. So anything that's high energy contact sport, football for males, basketball and soccer for women. Lacrosse is another popular sport to tear your ACL. These are the things that result in most of our tears. So 70 to 75% of them are actually going to be non-contact injuries where we have either a hyperextension or a twisting event, maybe some sort of deceleration event. But the thing to keep in mind is these are actually fairly devastating injuries. The ACL itself has a poor healing capacity. So to retain to get the stability back in the knee, we need to do a surgery to reconstruct it. We'll talk slightly about ACL repair here in just a little bit, but frankly, it hasn't been shown to be that effective. These injuries can result in a loss of a season or more. We've seen quite a few of these injuries in NFL players this year, and almost always that results in the entire season loss. And then there's long-term clinical sequelae to keep in mind because they are commonly associated with meniscal tears, additional ligamentous injuries, and down the road chondral injuries as well. So for diagnosis, clinically, there's the anterior drawer test, which is shown here nicely in this diagram, where the knee is at 90 degrees, and we try to elucidate that anterior translation of the tibia. There's a Lachman and a pivot shift test, which I have videos to show you here in just a second. And it's important to remember that the ACL exam is very good at picking up these tears. So MRI may be done to confirm the ACL tear, but it's also to look for these additional injuries that we'll talk about here in a little bit. In certain situations, the physical exam can be a little bit limited by guarding or fusion can kind of make it more difficult. But here's a video showing the Lachman. So they're performed at around 20 to 30 degrees of flexion. And then for the grading system that you guys probably see in all your orthopedic surgery notes, this is just a nice, so an A has a firm endpoint and B has no endpoint. And then there's 1, 2, and 3 grades, just dependent on how much anterior translation there is of the tibia. And then for the pivot shift, we can see here that the knee is, a valgus stress is applied and put into flexion, and they're feeling for a clunk as they go through this range of motion here. And so a decent number of patients who actually have had ACL reconstructions may still have a positive pivot shift afterward, which is kind of the idea behind the anterolateral ligament reconstruction. Although, like Dr. X said, we're not seeing too many of those these days. Imaging wise, the diagnosis is usually not too difficult. You'll probably see an edematous mass like we do here along the tibial side. Most of these tears occur on the femoral side or in the mid substance. So the tibial side would be a less common place to tear. And so usually the retracted fibers will be on that side. You may see what's called an empty notch sign, which I'll show you here in a minute. You may see focal disruption of the ligament itself or an abnormal orientation, like we talked about with Blumenstadt's angle, which if you look in this case, this would be an abnormal Blumenstadt's angle, where we can see that those two are no longer in parallel here. Complete versus partial tears. Partial tears do occur. They're not common, but they're more likely in skeletally immature patients. This nice study done in AJR back in 2005 showed that about half of them would be complete in skeletally immature patients, and then a quarter are partial and a quarter actually ACL avulsion injuries. The skeletally mature patient, a significantly higher rate of complete tears, up to 88%. These can be tough diagnoses, both clinically and on imaging. The Lachman test may not necessarily be positive in these patients. So the MRI is going to play a little bit larger role in making that diagnosis. The thing you want to look for is some abnormal signal within the ACL. Maybe you'll have some disrupted fibers, but you're going to have to really evaluate and see that there are still some fibers that remain intact. You may or may not see the contusion pattern with this, as well as we can see in this case, where there's been at the femoral attachment, there's been a partial tear here, but we can see that some of the fibers are intact and they do have an actual contusion pattern here. Here's this same patient, so axial and sagittal, showing some of these fibers remain taut as they go through the notch here. So this was a high-grade partial tear. In the literature, it's reported that these are about 10 to 28% of tears overall. The MRI sensitivity is decreased a little bit, 50 to 80% range, just because you will have some intact fibers and you can miss this portion, partial tear here at this posterolateral bundle at the femoral attachment. Mucoid degeneration is another abnormality we see of the ACL. It's not really too confusing for the diagnosis. You'll see increased signal and actual thickening of the ACL itself. You should see nice taut fibers still running through the ACL here. People talk about a celery stalk or drumstick appearance, which you can see nicely on this example. So here's your celery stalk if you're healthier and you prefer that, or if you're more of a meat eater and you like the drumstick appearance, there you go. And then chronic tears, actually, I find in certain instances can be kind of stealthy. You want to really evaluate the morphology of the ACL because it has a tendency to scar to different structures nearby. So it can be difficult to diagnose because there may still be some degree of stability depending on where it scars to clinically. And then there's no contusion pattern anymore. So there was a nice study done in skeletal radiology showing that most of your contusion patterns are going to resolve by around 8 to 9 months. And so if you're past that point, you may not have that to tip you off. We had one earlier this week where the patient had a injury actually back in July and didn't have the contusion pattern and had a pretty stealthy subacute ACL tear. So it's something to keep an eye out for. It may actually even appear taut or intact, depending on what it scars to. So here's a pretty clear chronic tear. This is a nice example of the empty notch here. We can see a PCL, but there's no ACL here. And then we can actually see some retracted fibers here on the sagittal. Here's a little bit different one where we can see that it has kind of scarred a little bit to an abnormal position on the femur here. And we can see on the coronal that has a somewhat lax appearance, and we would expect to see it a little bit more towards the midline of the knee here. And then this one was another recent example that's a little bit more subtle, where here at the tibial attachment, it actually looks pretty good. Mid substance, maybe you say it looks a little bit, a little funny right there. It's a little closer to the PCL than normal. And then here, it actually goes kind of straight up, and we can see that at the femoral attachment that we were talking about earlier, we just see some fluid here. The axials can be quite helpful in these cases too. So as we follow it up right here, we can see that it doesn't actually make it over to that medial wall of the lateral femoral condyle, and actually appears like it's scarred to the PCL in this region. So some secondary signs that we may see, particularly in the acute setting, you're going to see a joint effusion in most of these cases. You may see a lipohemarthrosis. It's uncommon, but you may see it in an ACL avulsion, like in this case where they've avulsed one of the tibial spines. We can see it here on the lateral, and then they have a small lipohemarthrosis. And then the corresponding MRI for that patient, we can see that that fragment is mildly elevated. It looks like it has some posterior intact periosteum here. This is another recent case that we had where the patient came in with a recent knee twisting injury. We can see that there's a lipohemarthrosis here on the lateral and on our sunrise view, but I'm not sure that I could call a avulsion. If you look closely right here, you can see there's this extra density that would be pretty tough to call prospectively, but here's the patient's MRI. We can again see that lipohemarthrosis here, and then here's that bony fragment that I pointed out on the radiograph. So this was a femoral sided ACL avulsion. Here's that bone fragment again on the sagittal, and we can see that lipohemarthrosis again. So they do occur on the femoral side, although it's much less common. So as far as the tibial spine avulsions, there is a typing system. The type 1 are going to be non-displaced. Those may actually be treated non-operatively and with a cast. Type 2 has the posterior hinge, which is the one I showed you, and those are usually going to be tacked back down. And then type 3 is when it starts to become displaced, and there's a type 3 plus that includes a rotational element to the displacement, and then the type 4 is going to be displaced and comminuted. So here's an example of one that was fixed with screws. Here's an arthroscopic example of one that was fixed with suture. The cutoff, from what I'm told by my orthopedic colleagues, around 1.5 centimeter fragment to be able to actually put some screws in there. So the femoral sided one is they're talking about how to treat that one best and plan to operatively fix it, probably with sutures. Another sign you might see is PCL buckling on MRI, as we can see here that this PCL looks a little bit redundant. That has to do with the anterior translation of the tibia, which we'll talk a little bit more about here in a minute. But normally the PCL has a little bit straighter angle to it, whereas in the buckling, you'll see that it has starts to may even take on a candy cane type appearance. Contusions are seen in the majority of cases in the acute setting. The classic pivot shift contusion pattern that we see here on this sagittal T2 showing a contusion along the lateral femoral condyle and posterior lateral plateau. Those positions may change by a few millimeters in each direction, just depending on the degree of flexion that the patient was in at the time of injury. And then we also want to keep an eye out for these medial-sided contusions along the posterior medial tibial plateau, because those can tip you off to injuries on the medial side as well. The other things to keep in mind about contusions is that they're a footprint. They leave a mark of what exactly happened during the injury event and can tip you off to what soft tissue structures to look for. But what is a contusion? It's just basically areas of hemorrhage and trabecular microfracturing. So some people use the term edema-like signal to describe these because it's not truly bland edema, and there's actually some hemorrhage and trabecular microfracture in there. It's also important to remember that contusions aren't just compressive injuries. They can also have a tensile component to it. So here we're looking at a sagittal fat suppressed T2 image, and we can see some edema here in the fibular styloid. So this was actually more of a tensile type of contusion from these lateral stabilizing structures in this case. How does the pivot shift happen? Well, here's a nice diagram showing you the tibia here is the darker, more bold line versus the femur. And we can see during the injury, the tibia translates anteriorly, and there's a little bit of a rotational component here. And you can see that compression along the posterior lateral tibial plateau and lateral femoral condyle. There may be a contrecoup type of injury or versus a tensile injury that can result in medial-sided contusion patterns as well. And then here we are back to our normal alignment with the contusions after the injury. So moving on to the sulcus sign. The sulcus sign is just a radiographic finding when you have a pivot shift that's enough to actually result in some depression. So this is actually a normal structure of the knee called the condylopatellar or terminal sulcus, depending on what you prefer. If it's more than 2 millimeters deep, then we may call a sulcus sign, especially in the appropriate setting, appropriate injury setting to call that sulcus sign. Tibial subluxation is another secondary sign. We may see that tibia floating anteriorly. So if you draw a line down the posterior lateral femoral condyle and one down the posterior aspect of the lateral tibial plateau, and that distance is greater than 7 millimeters, then you have a good sign that that tibia has translated anteriorly in an ACL deficient knee. You can see it here on this radiograph, even though it's not the best lateral because there's a little bit of rotation there, but it was enough to call at the time. The last thing, as far as secondary signs, Segond fractures. See a little avulsion injury from the lateral aspect of the proximal tibia here. There are a lot of associated injuries that we see with ACL injuries, particularly meniscal tears, more commonly lateral in the acute setting, and then more commonly they're on the medial side in the chronic setting. And that's because in the chronic ACL deficient knee, the posterior horn of the medial meniscus can actually act as a stabilizer to anterior translation. So since you don't have the ACL accounting for that anymore, that medial meniscus takes on a larger load and is likely to fail. We also see additional ligamentous injuries, posterolateral corner and posteromedial corner injuries, which we're not going to talk too much about today, but we'll hit on them real quickly. So as far as meniscal tears, these result as a combination of forces. So it may be entrapment, especially along that posterior horn of the lateral meniscus from the pivot shift injury. There may be some rotational or tensile stresses that also result in these injuries. So this is Adam actually on Twitter posted last night a nice example of an ACL tear with a flipped meniscus fragment. Here's another example for you where we can see that the posterior horn of the meniscus is not in its normal position. We have a double anterior horn here. So the posterior horn is flipped forward in the anterior aspect of the knee. Those popliteal meniscal struts are going to also be disrupted in this case. But more typically what we see maybe a oblique radial tear kind of here where the posterior root and the posterior horn are meeting. We can see in this case. or you may even see a more peripheral kind of vertical longitudinal tear. So this one actually kind of really involves that very far peripheral posterior horn of the lateral meniscus and those popliteal meniscal struts that help stabilize in that posterior lateral corner. There's a specific type of posterior horn lateral meniscus tear called a Risberg rip that we should talk about too. These are longitudinal tears of the posterior horn of the lateral meniscus, but they originate where the meniscofemoral ligaments attach to the meniscus. And if you need a measurement, about 14 millimeters lateral to the PCL is a good one. So here's an example. The orange arrow is pointing to that ligament of Risberg. As it comes in, we can see that it never properly joins with the posterior horn of the lateral meniscus. And we can see that kind of vertical longitudinal tear right along where that interface would be. And this constitutes a Risberg rip. So let's move on to the medial side. In the acute setting, there's something called a ramp lesion that you guys may have heard of. These occur in 9 to 16, maybe even up to 20% of acute ACL injuries. It's been underreported because it's something that wasn't well understood or known about too much before the past few years. The ramp just refers to the appearance of this area. So it's the posterior horn of the medial meniscus, and where it meets at that meniscocapsular junction. Kind of looks like a ramp that you might want to go ride your bicycle off of, when you were a kid. But these usually involve the posterior horn of the medial meniscus and meniscocapsular attachments. Previously, MRI has been reported as pretty insensitive in the 48 to 72% range, mostly because we just didn't know to look back there. But like I said earlier, if you see that posterior lip edema or edema-like signal on the medial tibial plateau, that's something you want to pay close attention to, because it's been reported in up to 95% of cases where that contusion pattern is present. You either have a meniscal tear or meniscocapsular injury. So historically, they've been underdiagnosed. The thing that's important about this is they can be difficult to visualize arthroscopically. So it's important to talk about it in your report, so that because sometimes the surgeons need to perform a special portal to access that area well and really evaluate it. It is important for stability. Like we talked about, that posterior horn plays a role in anterior translation. It also has some roles in posteromedial rotation. Here's a nice diagram from skeletal radiology this year, kind of showing that ramp lesion area. And we can see that there's a meniscocapsular ligament, a meniscotibial ligament, and then the peripheral aspect of the posterior horn of the medial meniscus also makes up a portion of this. There are a few grading systems out there. I don't use them. I usually try to determine if there's something. Well, I use the terms meniscocapsular injury or meniscocapsular separation, and then try to distinguish that from a peripheral posterior horn meniscal tear. So in the meniscocapsular injury setting, those are going to be cases where there's some edema there, but it doesn't look like it's frankly disrupted. And what we were seeing when I was at UVA and here at MUSC too, is that those patients, by the time they get to arthroscopy, have a tendency to heal. So it's something that I bring to their attention. But by using the term meniscocapsular injury, we expect that it might heal by the time that they get to surgery, versus a separation where there's actual frank fluid separating those two. So this would be more in the separation area, where we can see there's a good bit of distance between that posterior horn of the meniscus. We don't see those ligaments well, and the capsule is displaced posteriorly here. Here's an example showing a peripheral posterior horn medial meniscus tear. And so you can see how that might be difficult to see at arthroscopy. This one extends into the meniscocapsular ligament as well. Additional ligament injuries that we might see include MCL and LCL injuries. So this is an example where they had a little bit of edema along the proximal LCL here, and then actually had a grade 3 MCL injury. And as we follow this MCL distally, we can see that it never makes it down to the tibia. And you can see on these images, orange is pointing to your MCL itself, and then the blue is highlighting the pes anserin tendons here. And we can see that it actually is displaced over the top of the gracilis here. I'm sorry, sartorius here. And so this would actually be a Stenner equivalent grade 3 MCL injury, where it's stuck outside of that tendon. Here's another example showing an LCL sprain with an ACL injury. So we can see the LCL here has a slightly wavy appearance, and then we can see the edema around it. the posterolateral and posteromedial corner injuries are important to recognize because there are, especially posterolateral corner injuries, are commonly implicated in ACL reconstruction failures. So that rotational instability may put additional strain on the ACL graft and result in recurrent tears. So here's an example just showing all that edema along the arcuate ligament. Popliteal-meniscal fascicles are disrupted. And then there's a few structures that play the primary role. These are largely diagnosed whether or not they need to be operatively fixed through stress images. We'll do stress radiographs to see how much they open out in varus stress for a posterolateral corner injury. But the main structures you want to evaluate on MRI include your LCL, biceps femoris tendon, this structure right here, the popliteofibular ligament, and that popliteus tendon, as well as the arcuate ligament. So here's a nice posterolateral corner injury with what looks like an arcuate fracture. This one's a little bit different, as I'll show you here on the MRI, so we can see this just confirms that little fracture fragment. And then if we look on the coronals, we can actually see that LCL biceps femoris conjoined tendon here is inserting in its normal spot, and there's the bone looks like it's present. What we do see here on this image is that bony fragment that has been displaced, and here is the popliteus tendon, and the popliteofibular ligament itself actually pulled off the bony fragment in this arcuate injury. So Dr. X kind of hit on the ALL for us a week or so ago, but it was discovered by Dr. Segond. The main role it plays is some rotational stability and flexion, very little to no contribution to anterior translation. And the idea is that these patients may still have a positive pivot shift after their ACL reconstruction. As you heard, some people are doing ALL reconstructions. Our surgeons here will do them in certain instances, and they're actually largely doing something called a lateral extra-articular tenodesis, which is a non-anatomic way to kind of try and repair that lateral capsule. But here's what it looks like on MRI. So it's going to be posterior to the IT band, but anterior to the FCL. So we can see a little bit of the fibular collateral or lateral collateral ligament here. Here's the popliteus just deep to it. And then we can see this meniscal arm and a tibial arm of the ALL. As far as treatment for ACL tears, it's important to remember that there's poor healing of the ACL itself. It's been reported of a 40 to 100% failure rate after primary repair. So this is going in and trying to repair the native ligament. So repair's largely been abandoned, but there are a few places experimenting with it out there. So we'll have to keep our eyes peeled for that and see where that goes. But the ACL itself has this lack of ability to heal. ACL reconstruction is the treatment of choice. You can do non-operative management in certain situations, such as low demand patients. There's a bunch of different options for reconstruction, like we talked about. So you can have a patellar bone, patellar tendon bone, hamstring, or quadriceps grafts. And then there's also allograft options, which each have their own benefits and risks, as you can see here. So autograft or graft from yourself, there's no risk of disease transmission. They're lower costs and lower re-rupture rates than allografts, which may have been irradiated, which can kind of alter the tissue. Allografts, you don't have any donor site morbidity or pain. So I've actually had an ACL reconstruction myself and had the bone, patellar tendon bone, and I can tell you that the donor site pain is pretty impressive. The surgery tends to be a little bit faster, less scarring from an allograft, and then the graft size, you have a little better idea beforehand. So the bone, patellar tendon bone autograft, you get bone blocks on each end, which is why it's kind of the gold standard graft at this point, because you can get bone-to-bone healing on both ends. And it also helps maintain that hamstring as a medial stabilizer. And like we talked about earlier, especially in female patients, the hamstring playing a role in anterior translation, resistance to anterior translation of the tibia. They do have some complications for bone, patellar tendon bone, one being patellar fracture, as we can see in this case. So there was a nice fracture here through the patella, which you can see on the sunrise and AP views. The other thing is that, which I can attest to, is that you do have a good bit of anterior knee pain with any type of kneeling activity. So that's something that the surgeons try to keep in mind. The quadriceps is something we're seeing a lot of here, like Dr. X spoke about. Uh, Dr. Harris Sloan is one of our sports surgeons, and he really likes to use this quadriceps tendon autograft just due to the quality of tendon. It can be pretty versatile in terms of the harvest. And then it helps preserve normal anatomy a little bit better, a little bit less donor site pain, and you still also maintain that hamstring. Then the hamstring is one of the most common grafts. There's less donor site pain because you're not taking any bone with it most of the time, or you're not taking any bone with it. There's no risk of patellar fracture. There has been a reported higher re-tear rate in the literature, although that tends to or seems to be a minimal, if it's even true. And then a little bit less predictable graft size. As far as the ALL, you may do an ALL reconstruction, or like I said, a non-anatomic procedure would be a lateral extra-articular tenodesis. Our surgeons are doing them in the setting of this patient who had a recurrent tear and still had a significant amount of rotational instability. And this patient is post-op from a lateral extra-articular tenodesis, and they just put a bioabsorbable screw here along the lateral femoral condyle, which you can't really even tell on that image. So let's move on to the normal imaging appearance postoperatively. It depends on the time interval from surgery. So initially it'll have a nice black appearance on MRI. And then as time increases from surgery up to about a year, maybe even up to 2 years, as that undergoes ligamentization, you get some graft remodeling, and it may actually increase the signal. And then one other thing we always want to do is evaluate the tunnels for their position and their size. So here's the process of ligamentization. We can see here on post-op day 3, and then several months afterwards, 12 months, 24 months. We can see that the graft signal intensity actually increases over time here, and then starts to return back to normal by about 2 years. So it's going to be 1 to 2 years before it starts to look normal again. This is actually some MR images of my knee. So this is what it looks like. I had my ACL done in 2003. This is from when I was a fellow in 2016. So a 13-year-old graft. And you can see it's got a nice black signal intensity to it. It looks nice and taut throughout. Like I talked about earlier, a lot of patients are going to have some chondral issues down the road from these injuries. And that's something to keep in mind when you're evaluating these post-operative patients, is to look for meniscal tears and chondral injuries as well. So this is just some more images in the coronal plane here, and then axial and coronal plane images here. This is a hamstring graft, obviously not me anymore, but we can see that there's several different strands of the graft itself here. Tunnel widening seems to be a little bit more of an issue with hamstring grafts rather than the bone patellar tendon bones. So let's move on to complications here. Quite a wide variety, things such as roof impingement, the cyclops lesion, or arthropfibrosis, which can be a focal or a diffuse form. You can obviously have recurrent tears where the graft is disrupted. A lot of the times those are new trauma, though it doesn't necessarily have to be. Sometimes roof impingement can lead to it. There's other injuries like I talked about, meniscus, chondral injuries, and then hardware complications as well. So what is roof impingement? It can occur along the roof or the sidewall of the intercondylar notch. It may be due to bad tunnel positioning. So what you want to evaluate in terms of the tibial side of the tunnel is that it should be parallel and posterior to Blumenstadt's line. So if we drew a line down the roof of the intercondylar notch again, we should see that tibial tunnel is posterior to it and parallels it pretty well. So if you have it too anterior, you may end up with a flexion contracture and an impingement of the roof on the graft itself as they try to extend, which can result in recurrent tears. You can have osteophyte formation like we do in this case at the orange arrow here. You may have some scar tissue forming there, and those can all be causes of roof impingement. So for the tunnel positioning here, so there's Blumenstadt's line, and then this would be a too far anterior tunnel. And then you can have too far of a posterior tunnel too, where the graft ends up too vertical. You don't have as much stability as you would like, because they're trying to maintain the concept of isometry when they reconstruct these, so that the ligament, the graft itself, remains the same length throughout. the full range of motion. Here's a example of a slightly vertical tunnel, but they also had some osteophyte formation that resulted in some roof impingement. And we can see that there's some partial tearing of the graft here on this fat suppressed T2. The other complications, arthrofibrosis or the cyclops lesion. So this is focal arthrofibrosis here. Most of the time it's kind of got a darker signal, like in this case where we see it. And then there's a more diffuse form of arthrofibrosis here where you can see just some thickening of along the capsule anteriorly. Here's some arthroscopy images from a recent case that we had with a large cyclops lesion. So we can see the cyclops here kind of coming out of that anterior intercondylar notch. Here it is up close and personal, and that's what it looked like after they had resected it. So we still had a nice intact ACL graft, and you can see how much more room there is now so that they can actually get to full extension. Recurrent tears, like I said, are usually new trauma. It may be biologic failure, particularly in the setting of an allograft. It could be surgical failure from tunnel positioning or failure of the hardware. And what we want to really look for is disruption of that graft. So we can see here's a nice example of a recurrent tear. You can see there some susceptibility from their hardware. The tunnel itself actually looks pretty good on the femoral side here. On the femoral side, you want it to be, it depends on which knee you're looking at, but a right knee, it should be coming out where at approximately the 11 o'clock position, and on your radiographs, it should be where Blumenstadt's line meets the posterior distal femoral cortex. And here we can see that the graft is disrupted on our sagittal as well. Here's another example of a recurrent graft tear. So there's no fibers running through here. There's no nice taut looking fibers. There's increased signal in there as well. And then another example. It's important to keep in mind that a lot of these patients are going to have meniscal tears and chondral injuries associated with it. And then the other thing to keep in mind about recurrent tears is that these patients are much less likely to return to play. Maybe even as high as 40% of these patients may not return. It takes about 8 to 18 months to even return to play at this point, and they have a fairly high re-rupture rate in these recurrent tear patients who go on to revision. It's also important to keep in mind that they have ipsilateral knee surgery for other reasons, like I talked about meniscal tears and chondral injuries. So for patients who underwent revision surgery, a nice study done by Ocaro and his group of 24 NFL players who had a recurrent tear and revision surgery from 2007 to 14, 19 of them returned, but all of those patients played in fewer games and in less seasons than their counterparts. So it's can be a fairly devastating injury. Risk factors to help to keep in mind for patients who might be at an increased risk for recurrent tear. A lot of these tend to occur fairly early after their ACL reconstruction. So tibial slope, an unrecognized posterolateral or posteromedial corner injury, the notch size, so that kind of goes along with the female patients like we talked about earlier. Here's a case that had a posterior tibial slope that anything above 14 degrees is going to be considered an increased slope, and those patients may actually get a tibial osteotomy at the time of their revision surgery, which would put them out even longer. Here's an example of a patient who had recurrent ACL tear. Obviously, their meniscus is quite abnormal, and then they have had an osteochondral allograft procedure as well. So that's not doing so well. And then we can see more posteriorly, they've also got some recurrent meniscal tearing. Other things to talk about, the hardware itself can fail. So we've got an immediate post-op image here, and then we can see that this femoral interference screw has migrated into the joint. Here's another example where there's loosening. So we've got the tibial interference screw that's backed out into the soft tissues. This distal femoral endobutton is important to make sure that it stays along that lateral distal femoral cortex. In the immediate postoperative setting, it can get caught in the soft tissues sometimes and can cause pain and kind of a snapping sensation for patients. Or in this case, where the suture has failed, it's kind of migrated from its normal position. A couple more examples where this one has a migrated interference screw within the joint. This one had one that fractured and migrated into the joint as well. So that first image where it migrated into the joint, here's what it looked like at arthroscopy. So it's a heck of a loose body or intra-articular body in the joint there, if you ask me. And then lastly, we'll talk about tunnel widening here. So the tunnel widening is kind of dependent on the original technique, but usually people use a cutoff around 10 to 11 millimeters. And it's important because in patients who have significant tunnel widening, they're going to have to go through a staged revision where they graft the tunnel so that they can do a revision ACL reconstruction. I've shown here, this is not really how you want to measure it. With the red line, the orange line is a little bit better way to measure the tunnel width. Because you have to take into account the obliquity and you want to try and be as perpendicular to the tunnel as you can to try and get an accurate measurement on it. Here's an example of tunnel widening with a recurrent tear. We can see this retracted graft fibers here and a good bit of tunnel widening on both the femoral and the tibial side. Here's the same patient just showing the coronals. Again, quite a bit of tunnel widening on both sides here. And then here's a CT that was done prior to their staged revision. And then a few scope images here showing. So this is that retracted stump of ACL fiber that we saw on the MRI. Here's what the tunnel looks like after drilling it and then placing the bone block and hopefully seeing it there. So you have to give it several months to heal in here. And then you can go and have a revision ACL, which is why some of these revision patients will be out longer than the typical 9 months to a year of a initial ACL reconstruction. So this is what the patient looked like afterwards. So that's all I've got for you guys today. I'm happy to take any questions if you have some, and need to say special thanks to Dr. Eric Foss for some of these cases and Harris Sloan as well for a few slides.
Thank you so much. Ooh, that was really loud. We have a couple questions that came in. So I'll start from the top here. Do you prefer X-ray, CT, or MRI for assessing the orientation and angulation of ACL tunnels? What parameters do you use in your practice to report alterations in the position of the tunnels, very anterior or very posterior?
That's a good question because it can be kind of difficult, particularly if it's one of your surgeons who's done it and you don't want to be overly critical of their procedure. I evaluate the tunnel on the radiographs predominantly. I like it for that, especially if you have good radiographs. You can evaluate it on the MRI or CT. There's no reason not to, but personally, I prefer to do it on radiographs because I just feel like you get a better overall feel of where they are. As far as reporting it, I usually, particularly if it's done in-house, we'll just kind of report exactly where they are and won't say, poor tunnel positioning resulting in, roof impingement or something along those lines. I'll usually just kind of report them out and say, there's slightly anterior positioning of the tibial tunnel, talk about whether or not there's some tunnel widening and kind of leave it at that.
Got it. Second question, and this is something we sometimes struggle with, when we're reading out, looking at the ACL, as you mentioned, the ACL has typically increased signal intensity in it compared to other ligaments such as the PCL. What is your threshold for describing mucoid degeneration? What imaging findings do you use to differentiate the two if it's not, as obvious as the case you showed before with the celery stick appearance? And then the second question, which is a follow-up of that, is what would be the normal expected appearance of the ACL graft over time?
So first question on the mucoid degeneration, I like to see one increased signal, but I'd like to see it look thicker than normal as well to come down on that. Reading enough knee MRI cases, you'll see that everyone's a little bit different in their maybe in their orientation or signal that they have in their ACL. For me, it's really to see that thickening and increased signal, and then obviously in that setting, you want to make sure that there's no disrupted fibers as well. The second question was about the changes in the graft signal over time. So obviously you want to know your time interval from surgery if you have that data available to you. And then expect, if you're not within a week or two of surgery, that there should be a little bit of signal in there normally, as long as they're not, until up to about 2 years after their surgery.
Got it. Next question is, are you using standard sequences for knee MRI, or are you delving into the volumetric rapid knee MR 3D type sequences?
We have not gone that route yet. We're still just doing conventional. That's a good question, though.
The other question we have is, if you see the meniscotibial and meniscofemoral ligaments, do you feel confident in excluding a meniscocapsular junction injury? And the follow-up to that is, what do your surgeons prefer in terms of using the term ramp lesion, meniscocapsular junction separation versus peripheral longitudinal tear?
So in that setting, if you can see both those ligaments, obviously you also want to evaluate that posterior horn of the medial meniscus to make sure there's not a ramp lesion. But if I want to make sure that they're intact and there's not any abnormal signal there. As far as the terminology, I will typically, when I'm reporting one of these out, say, like I kind of talked about in the talk there, meniscocapsular injury versus complete or frank separation. And then usually, or if you have a peripheral meniscal tear, I'll actually say, meniscal tear involving the peripheral third of the medial meniscus, and then usually put, ramp lesion in parentheses on those cases.
Got it. And I have one follow-up question myself. You showed your knee MRI, and it seemed as though you had some bone marrow edema-like signal. Curious if that's symptomatic or...
It depends on the week and how active I've been, to be honest with you, because I definitely do have symptoms when we're more active. But, being a radiologist, most weeks are not too active. So on those weeks, I'm good.
Makes sense. All right. Well, that's all we have for questions today. So really appreciate taking the time to talk again. And I'll put your talk up on YouTube channel and put out a link on Twitter. To the people who are watching, thank you for watching. And if you're not following Cody on Twitter already, or seeing his podcasts or listening to them, don't forget to take a look. All right.
Thank you so much.
All right. Bye-bye.